Hi, my name is Stephanie Coombes. I'm doing my presentation for BCIT Breastfeeding Theory 7155. The topic I chose was breastfeeding and feeding a baby with Down syndrome. I hope you guys enjoy it. We've been asked to use the situated clinical decision-making framework. So we start with knowledge. We're going to look at cues, judgment, decisions, and an evaluation of outcomes. This is a more advanced version of the traditional nursing model of assessment, planning, intervention, and evaluation. And the reason the emphasis in this model is the fact that decision making is a really complex process. And I'm going to use this model to connect the two challenges outlined in my presentation. So we're going to look at mastitis, an infection caused from poor milk movement and a poor latch. And these are both really common problems when we're going to breastfeed a baby that has Down syndrome. If we can use the model to understand the links between these, hopefully will lead to having a healthier baby and a faster healing time for the mother. Knowledge is the center of this framework. It's going to impact all the pieces as we move around. And Down syndrome babies are known to be less breastfed compared with other children. And so support from a healthcare point of view is super important. The word healthy is interesting. Remember, Down syndrome is not a disease, it's a syndrome, but they do have often more advanced medical needs where, say, the immunity of breastfeeding is even more important. So Down syndrome is a chromosomal abnormality that we see in babies. So they've received an extra copy of chromosome 21. Babies are born with 23 sets of chromosome, usually all in pairs. Baby with Down syndrome, they have a partial or a complete extra one thrown into number 21. We don't know all the reasons for it. One big factor is maternal age. And so you can see up here some common physical signs of breastfeeding, so decreased muscle tone, so it's physical signs that are listed there. There's also intellectual delay, that sort of thing. This is diagnosed on genetic screens, and it's different in every province, the screening tests that are available. It's often diagnosed at birth as well. Families that have had a screening prior to are much more prepared for breastfeeding than a family that receives this diagnosis at birth. Also, due to some of the genetic screening, there's also less babies that are born with Down syndrome, and that also leads to less support for breastfeeding moms. Excuse me. So if we're going to look at how does Down syndrome affect breastfeeding, so just for the physical characteristics there, that these babies often have like their tongue is protruding most of the time, and part of that is due to their systemic low muscle tone. So that's also going to impact their ability to latch. If you think about the muscles in their neck, in their lips, in their tongue, in their jaw, it's going to be really hard for these babies to coordinate the sucking and the swallowing and the breathing. They also have a narrow palate, a short neck, so positioning is going to be harder. They have higher rates of respiratory and GI infections, higher rates of prematurity, and they tend to be much sleepier and get really tired when they're trying to breastfeed. Some can this be related to the cardiac conditions that we also see in Down syndrome. Down syndrome babies also have a different weight gain. Every Down syndrome baby is different, so they're affected by the syndrome differently. So there is a huge range in IQs, there's a huge range in physical characteristics. If we're going to look at the other complication in our case, is the mom presenting with mastitis. Mastitis is an infection of the breast or breasts, and so it's most likely caused from like a cracked nipple, which has then allowed an infection in, and then a milk stasis, that milk just isn't moving. It's also impacted by stress, fatigue, and we call it mechanical, so like a poor fitting bra or really tight clothing, so just stopping that milk flow. So the mom's going to present with symptoms like pain, a really inflamed area over the breast, and flu-like symptoms, so like the fever and the headache and the fatigue. And it can get quite serious quite quickly. Usually it's seen in the beginning of breastfeed, say in the first 6 to 12 weeks, but it really can present at any time a woman is lactating. It's really important to remind mom to keep breastfeeding, to keep that milk moving, and it's fine to keep feeding a baby even if you have a breast infection. It's treated with warm compresses for relief, but most important is really swift treatment with antibiotics as well as pain medication. A complication of this is that it can reoccur. You can also develop abscesses and things like this. Excuse me. So if we're going to look at cues for this case, is that mastitis is usually seen following a breastfeeding problem, such as prolonged engorgement or poor latch that we're going to see in the first few months. And this is when any new mom is developing their breastfeeding skills. And so we really want to look at the mother-baby relationship at this time. This is potentially a first-time breastfeeder, but also breastfeeding a baby that's going to have more advanced needs. So we would need to have a really good record of the baby's input and output, and we need to perform an immediate latch assessment and a likely referral as well. Key questions that we would want to bring to this case, or I would want to bring to this case, just to keep in mind that babies, they can need that coordinated sucking, swallowing, and breathing. So issues with this can lead to apnea, bradycardia, aspiration, and is the baby showing any of these signs? Are we seeing anything that's like indicative of a swallowing disorder, like a poor suck? Are they turning blue? Is the milk pooling in their mouth? Are they developing lots of pneumonias? So is this baby being fed? Is that milk moving into the baby? What are the mom's breasts look like? Was there a delay in her getting a latch? Is this baby gaining weight and having good output? And you can look at if the mom had any support at all learning to breastfeed this baby with Down syndrome, or did she have a ring of mastitis in previous pregnancies? So remember that every baby with Down syndrome is different. So is the concern here the baby's really low tone? Is it really sleepy? Is it really having a really hard time with its jaw? Excuse me, with its jaw, or is it a combination of many factors? If we move around to the judgment part of our framework here, so we need to start looking at that connection between an ineffective feed and a milk transfer. Is this maybe causing the milk trauma and need to be, nipple trauma, which would need to be a factor that would need to be considered. And it's also really important that we assess this baby for adequate growth. So remember, we need to feed that baby as well as keeping that milk moving for the mastitis. The mom would really need an immediate nurse practitioner or MD consult for antibiotic treatment. And also we need to have a really fast lactation consultant to assess the latch. One thing to keep in mind in a lot of areas in Canada that there are no lactation consultants available. So we need to find getting some support for that mom if she is in a rural setting. We would want to get lots of information about the mom's experience with breastfeeding and have a look at her support network in this case. This would be really quite a top priority case because of the serious infection in the mother, as well as looking at the limited milk getting to the baby. And so again, we would be looking the support transfer being caused by a sleepy baby, or is this a baby with really low tone that's not having a good latch? So these are some of the judgments and the decisions that we would start to make using the model. In our decisions, obviously the first thing would be treatment of the mother's infection and discussing about the importance of continuing to feed on that side or both sides if there's a bilateral infection, and to pump if you need to, just to keep that milk moving if feeding is too painful. We would need immediate counseling for the mother and review of feeding that baby with Down syndrome. And you could look at working with some tips if she hasn't been taught them already about breastfeeding babies with Down syndrome. So a couple of good tips that I found was getting that milk flowing a little bit so the baby doesn't have to work so hard to latch on. We want to preserve all that baby's energy for feeding, not for positioning. So really good head support if they've got a low tone. You could hold their head high up if the mom's got really good volume and kind of overwhelming the baby's swallowing abilities. Some parents do find a nipple shield helps them latch. They can be controversial, but it's also been found to work well with babies with Down syndrome. In terms of holding, a cross cradle of standard football holds work. But if you look here, this is called the dancer hold, which was a position developed for low tone babies, and it helps keep the weight of the breast off the chin and help their head steady, hold their head steady. And so the middle three fingers will support your breast away from the baby, and then the pinky and the thumb actually help support their head, and that's been shown to have really good success in low tone babies. If the baby is overly sleepy, you may need to wake them up to stimulate them. If the baby's tongue is protruding out, there's some physio exercises that you can do to have the baby kind of help push their tongue down or learn to curl their tongue. So you can see here this obviously very sleepy baby, mouth open, tongue sticking out. So that's a very common way you're going to get the baby with Down syndrome's face. To evaluate these outcomes, we're going to look at, was the infection treated and is future reoccurrence going to be prevented? Has this baby been fed? Is there weight gain? And do remember that they do have a slower weight gain even if they're receiving enough nourishment. Have we seen that latch improve? Is that milk moving? A lot of families do find that bottles are really hard to avoid. But once that baby develops and gets better muscle tone, that can change. To conclude, the best way to prepare for raising a baby with Down syndrome is that you're going to have challenges just like any parent, but it can really help with bonding, especially if that diagnosis is a surprise. So ideally, the use of this model could help continue to feed that baby as well as prevent any complications in the mom. Anyway, hope you guys enjoyed my presentation. I'm just going to show my references here. Anyway, thanks again.